Good to see so many familiar faces, especially those who are sitting in the back. Okay, so with Be Interactive, so the first thing is to download 100% democracy. We will not proceed without 100% voting. So if you want to finish early, vote quickly. We obviously know the number of people in the room and we see the voting on the numbers. So if the number is there, we proceed. Got it? Everyone downloaded? Perfect. You voted yesterday, but you can vote today again. Okay, you've done it yesterday. MashaAllah, we have one of the doctors who attended one of the sessions last night and he's so keen he comes this morning as well. MashaAllah. Okay, first case. Very simple, straightforward case. I'm sure you see plenty of people like Ahmed every day. So Ahmed is 53 years of age. He works as an accountant, can consider it as an admin job. So the issue is that he doesn't have a physical job. He's a smoker for 10 years, busy in his work, and he's not a fan of sports in general. I mean, we give always the excuse of I'm busy, but in reality, it's possibly not just being busy, but I'm not interested in sports. He lacks exercise. He went to the doctors saying, I'm feeling tired, but his wife says he snores all night. So his main concern is he feels tired and been having epigastric pains at night. So it's kind of, I have epigastric pain, let me go to my family physician, let me take maybe some medicine. And by the by, he has pre-diabetes for the last year or two. HbA1c is 6.3. His mother had type 2 diabetes. He's also been diagnosed with hypertension, but he never really took the treatment. Kind of not convinced about why should I take treatment, I feel nothing. Okay? In clinic, on examination, his blood pressure is 148/83, and his BMI is 34. Got it? Do you want to summarize the case of Ahmed before we vote? So, 53 years of age, smoker, pre-diabetes, high blood pressure, and BMI of 34. Okay, you've just listened to the presentation of Dr. Fathia. So the first question, you need to vote. Is he eligible for cardiometabolic screening or not? Yes. Vote. Your yes or no should be by voting. Well, this is 18 people, 19 people, 24 now. It's a bit more. 30, 33. Come on, guys. Last two. So we all agree that Ahmed should be screened. Okay? Actually, for insurance purposes, talking to the people of insurance, we want to change the word of screening, assessment. Because screening sometimes means it's a luxury. Do it or not, maybe of value or maybe not. But it's an assessment. It's a comprehensive assessment. So what we were thinking, me and Dr. Hani a few days ago, that we will have now the new ACR, the new annual clinical review. Okay? So that will be the new ACR in the future, inshallah. So, Dr. Fathia presented this. We need to screen everyone with prediabetes, everyone with type 2 diabetes, and everyone with type 1 diabetes for over 10 years. The question that Dr. Hani was asking of why are we including prediabetes? Anyone wants to volunteer why we're including prediabetes? Yeah. So it's part of it, absolutely. The diagnosis of diabetes is 6.5. So do you think I suddenly have a massive change in my life, moving from an HbA1c? Let me assume that I'm Ahmed. So my HbA1c is 6.3 now. Am I going to be terribly different when it's 6.5? No, it's just a slight change in number. So it's a continuum. So the important point is to understand that my problem doesn't start today that authorities says diagnosis of diabetes 6.5. If the authorities move the diagnosis to 6.3, then people will be diagnosed with diabetes earlier. So it's a continuum, and that's the cause of the problem. But why do we say type 1 diabetes after 10 years? Why not from day of diagnosis? It takes time to have. Type 1 diabetes is an acute diagnosis. You will know this person have type 1 diabetes within days or weeks from being with a problem. So type 1 diabetes, we diagnose them pretty early, and they are usually pretty young as well. So two factors. One, type 2 diabetes and prediabetes keep going on for some time, and they are usually older. So these two factors are together. But we are the first guidelines to say we need to have a comprehensive assessment on all of these points for people with type 1 diabetes. So I want you to vote now, according to the presentation of Dr. Fathia, or your own possible. So what test you would like to do for Ahmed? Thinking of Ahmed now, okay? Fasting glucose, sleep study, lipid, renal function, or an ECG. Ignore the stress test, ECG. You can obviously vote for as many as you would like. Okay, so we all want to know his lipids, or nearly all. There's one person possibly, or two persons don't want to know his lipids. So what is required for the comprehensive assessment? Here are the points that have just been mentioned by Dr. Fathia. Why do we need to dig harder into the symptoms? Classically, we know that people with diabetes sometimes have what we call silent ischemia. They don't necessarily all present with the classic chest pains and shortness of breath. So we need to quiz them a bit more. So this guy, he was talking about epigastric pain at night. Is it gastric pain or is it not? So we need to quiz a bit deeper. The classic for vascular problems are related to effort. So we call it angina of effort, shortness of breath on exertion. Claudication means calf pain on exercise, not calf pain on resting, correct? But if I'm in a community that I don't exercise, if I simply leave home, go to my car, go to my office, then back home, and then maybe go to the restaurant or the mall, and shopping, someone else will lift it or bring it, delivery to the home. I will not going to wash my car, I'm not going to do any gardening. So many of us have other people to do their physical activity. So how will I diagnose any of these conditions? So we need to dig deeper. So really the symptoms are very important. And this is the same reason why we've included the ABI. Because if I'm not walking, then how would I know I got claudication? So that's why to test them, it's a worthwhile process. So here is, don't forget, this guy is talking about fatigue. Is it fatigue because he's tired? Or is it fatigue because maybe it's an undiagnosed cardiac problem? Maybe yes, maybe no. So not everyone will come to say, I have chest pains, or I have shortness of breath at night, or I have clear ankle edema. You're lucky if you get this, but we need to raise the profile. Now the ABI, it will be addressed in a nice case later, but it's an important, simple test to tell us about the circulation in the lower extremity. Very simple, could be done by all of you. It will be nicely addressed by the case that will be addressed by Dr. Salah. So all diabetes guidelines, the standard guidelines, the type 2 diabetes guidelines that we published 3 years ago, they will all have all of this. Annually, you need at least to have glycemic control, lipids, renal function, retinopathy, foot exam, which not frequently done. ECG is very important once a year, and also assessment for anemia. Anemia is not uncommon in people with diabetes. It could be related to other autoimmune condition, could be related to long-term metformin use in some people who are exposed, or could be simply poor causes for other anemia. What we're proposing extra is these two tests. The ProBNP, which is a lab test, I was just discussing with Dr. Hani. The cost of the test is not excessive. It's 120 dirham. That's what the people will be charged for. But the value of the test to pick early signs of heart failure, of atherosclerosis, is very high. The ABI is a software, is a machine, cuff blood pressure that you get once, do it, cost nothing afterwards. So the actual added cost of applying this is really very minimal. It is time that we need to develop this. Anyhow, back to Ahmed. So Ahmed, you done the lab for him. His HbA1c comes to be 6.5. His fasting glucose is 135. No cardiac problem. ProBNP is normal. ECG is normal. Renal function is normal. Feet exam is normal. Lipids shows LDL of 110, HDL of 43, triglycerides of 87. Remind you again, Ahmed is 53 years of age, smoker, blood pressure is 148/83, I think, and BMI is 34. Got the full picture of Ahmed? So, what is the risk category? What is the cardiometabolic risk category of Ahmed? Low, moderate, high, or very high? Please vote now. Don't influence your colleagues. Okay, so 75% says Ahmed is high, 25% says split between very high, one person thinks he's low risk and another person thinks he's moderate risk. Well, this tells me that even though Ahmed's case is very straightforward, simple, 53, just diagnosed with HbA1c 6.5, we do not have a uniform opinion about Ahmed. So that's why we need the guidelines. I have to admit that the group in Sharjah here have the highest score. This is the fourth session. We've done it in Dubai, we've done it in Abu Dhabi, done it in Al Ain. This is the high score, so well done, Sharjah. But the question is, why do we come with that score? So let's see the process. Who will be screen positive? And screen positive means very high. A person that you will have an abnormality on physical examination, such as absent pulses or ABI, or retinal examination that will be positive, or a person will have abnormal ECG, abnormal ProBNP, or abnormal renal function. Okay? These are the people that are considered as screen positive, which automatically will go to the very high risk. Ahmed has nothing of this. So we start to apply the United Arab Emirates cardiometabolic risk score. This is a score that we developed in our guidelines. So the score includes a number of items as explained by Dr. Fathia, but repeating is good. Age, above 40 or below 40, takes 1 point. Duration of diabetes, more than 10 or less than 10. And then number of cardiovascular risk factors. If he has 1, he scores 1. If he has multiple risk factors, he scores 2. So what Ahmed is, 53, that's 1. Duration of diabetes, 0. How many risk factors does Ahmed have? What are they? Sorry? BMI, so he's obese, smoker, hypertensive. 3 points, correct? So he scores what? 2. 2 plus 1 makes him 3. So where does he go? High risk. So well done for the 74%. Okay? What do we do for, sorry, Hani.
Right?
Yeah.
So is there any way that you can accurately determine that number?
Yes. So what we're concerned here is about some people with diabetes will be undiagnosed for a long time. In this case, Ahmed's last check was 6.3, and he's been checking on a regular basis. So now it's 6.5. So it's a diagnosis that happened within the last maybe 6 months or so. In fact, when we did the Dubai household survey, the undiagnosed diabetes, especially in locals, is very low because there is over investigation. So it's unlikely. I see so many people with HbA1c done maybe every 3 months, and it's at the same range. In the guidelines, we say when should it be repeated. But on the contrary, in the latest survey, expatriates, especially men, are not going enough for checks. And the rates of undiagnosed, maybe ladies because of pregnancy, they get checked. But men ignore their health and don't go unless they are really ill. So the rates of undiagnosed diabetes in men who are higher cardiovascular risk is high. So that's an important point. If you see a male in your clinic and he hasn't done an HbA1c and he's above the age of 30, do one for them. Okay? Sure. Can you raise your voice, or can we have the microphone flying? Am I on video now?
Since this is a cardio, I'm Dr. Shafaq, general physician. I would like to add on one point over here, since a lot of people who are researching are here.
Sure.
This is a cardio-renal presentation, and I'm seeing that there's a lot of cardio focus, Where's the renal? Because I myself experienced,
renal,
and my
the
colleagues.
second wave, inshallah.
Okay.
This is the cardiometabolic guidelines is quite long.
Yeah, no, I'm not asking a political answer. I'm giving a scientific, what I want to say. Per se, like people of my age, okay, people born in the 80s, who were raised in UAE, we were having exposure to a lot of, good wheat and good rice. So we became fatter, and we became pro-diabetic or pre-diabetic earlier in age. So me and my fellows, you can say, so many, are actually, there is one renal symptom I would like to add. That is getting up in the night and urinating. That starts maybe at 33 or 32, a very young age. So since that is not meant, this is a cardiometabolic risk stratification thing, yeah? So what I feel that since when we say a person having a diabetic mellitus duration and he gets a 0.1, we should add the pre-diabetic people also, because pre-diabetic people, some category has to be added maybe in your revised this one, because cellular problem, the diabetes is the disease of the cells of the entire body.
We agree with you, and we said that everyone with pre-diabetes must be screened.
Okay.
So if you attended the first part and the first part of the case, every person with pre-diabetes, 100% of you voted that pre-diabetes must be screened at least annually. Not at least annually. If that person with pre-diabetes is very low risk from the first screen, then you can extend it to every 2 or 3 years.
And I believe maybe in coming years the age will get revised from 40 to 35 or 32.
Well, we've just been reviewing the ADA guidelines. The actual age by the ADA is higher. We, in recognition of the risk in the country, we've reduced it to 40. Salah, you had a question.
So that insurance and all start accepting it.
Sure.
Yeah.
these two.
Oh, the congratulations, you reached 40. But I want to know the sample size of the Dubai household survey because it mentioned the sample size. You could.
There's 5,000, 2,500 national, and the other half is the
But
expert.
there are more than 5 million people in Dubai.
But that's a good sample because this is statistically significant.
Okay, inshallah,
And
we'll
I
improve
think
on
it's the
this.
same for the Ministry of Health and Prevention as well.
Okay, but my request, try to come down to 32.
We will look
Inshallah.
in the coming household survey how will
Inshallah.
probably it will even
Well,
lower than this.
we are mixing 2 points here. We're mixing the point of cardiometabolic screening and diagnosis of prediabetes. Okay, diagnosis of prediabetes, there is plenty of criteria that you need to do and apply to suspect that I'm 30 years old and I have features that make you suggest as a primary care physician to screen me for prediabetes. Once you screen me, once you diagnose me as prediabetes, I need the cardiometabolic risk. Salah, you had a comment.
Okay, so just to reinforce what Hani said, when it comes to the diagnosis, you see the criteria of diagnosing type 2 diabetes. If you go back 20 years, it's evolving, and you see the cutoff limits. It just gets changed on probably, I will say, 5-10 years time. But of course, whether we'll have enough evidence for us to go back and rechange the diagnosis. So probably in 10 years' time, the diagnosis of type 2 diabetes will be 6A1C. It was 7.5 when it started before, and now it's 6.5. It's like the GDM criteria. It's evolving very quickly. I just want to add another point is a duration of anything. It won't be 100% accurate. But what's reassuring is diagnosis of just the diagnosis of diabetes per se, it's a risk factor, and we are not going to lose those patients. They will go through the assessment as Fathiya mentioned in the first presentation.
Because you always have to take a number. When you go to an exam, someone says 50% is the pass mark. So is 49 really fail? But someone have to draw a line and says 50 is pass, 49 is fail. But in reality, the difference between 49 and 51 is only 2 marks. So we need to, from a clinical point of view, from a health point of view, you have someone with duration of diabetes of 9 years. Please consider it as 1, rather than be rigid, okay?
Excuse me,
There's no
doctor,
harm.
for the multiple cardiovascular risk factor, as per the book says, we always go by the factors which we are having. I would like to add one thing because I don't have the authority, I'm just a GP. Probably you guys can take it up. We must add one more factor, which is the processed food. Like we add smoking. Smoking is now accepted as a problem, and we take smoking as a risk. So we should have eating processed food as a problem. So if somebody in the detailed medical history time when we're asking, we need to know, are you a Texas chicken person or are you a home cooked chicken person? Are you eating this or eating that? That has to be a very important thing. And if that is added in the multiple cardiovascular risk, it should be giving us 1 point over there. Because a person who's on KFCs in his entire life, maybe at the age of 25 or 27, he'll be having all the cardiovascular risk and damage in his...
You have a good point, and it is likely that that person who is eating lots of junk food, that would reflect on their obesity, on their high blood pressure, on their lipids. So we look into the outcome rather than the process. Maybe that person goes to KFC and then go jogging. So it's not just about the food, it's about the lifestyle. Anyhow, back to Ahmed's case. Lovely, lively discussion. Hopefully the process will be easier for the next. What do we need to do by a person who is high risk? Do we add SGL2 or GLP-1 regardless of glycemic control? And the answer is not routinely indicated. But if he's above the target, you add an SGL2 or a GLP-1 with evidence. And the point here with evidence is important. So it's not just about the strongest on the market or the most fashionable, it's about one with evidence. The target blood pressure would be 130/80 or less using an A which is ACE inhibitor or angiotensin 2 antagonist, no preference. The target LDL for a high risk is less than 70 LDL using a high intensity statin, and you would consider antiplatelet. By consider means you discuss, you look into the risk assessment of the individual versus pros and cons, and then you come to a decision. Okay? So that's the plan for a person who is high risk. So accordingly, let me ask you, Ahmed is 53, no previous history of anything. You screened him and he came to be negative. He has hypertension, obesity, and is a smoker. What is the target glycemic control or HbA1c for Ahmed? Come on, guys, vote. That's a simple question. Commit yourself to a number. Okay, so 85% of us are saying Ahmed should go as low as possible, less than 6.5. And the guidelines are very clear. The guidelines nowadays are saying the least possible without causing harm, without causing undue hypoglycemia or possible harm for the person. Especially for who? For a person who the life expectancy is long. So if I'm frail, then there's no point to try to get my HbA1c tight. But if the life expectancy for me is another 30, 40 years, then try to get my HbA1c as good as possible, provided that will not cause harm such as excessive hypoglycemia or so forth. So from the case of Ahmed, he's not on any medication for diabetes yet, and he has no other comorbidities, so we need to try to get him as good as possible. Even remission of diabetes would be great. So accordingly, what would you start Ahmed on? Metformin, GLP-1, SGL2, SU, or a combination of metformin and a DP4 inhibitor? And forget about restrictions, just think guidelines. What is the optimum treatment that you will be able to prescribe? I think we have the maximum vote, mashallah, 42 people now. So let me take you again. So here is the recommendation. Do you see on this recommendation metformin? No. The new guidelines, the ADA and ESD, have liberated the issue. Metformin is not the routine first line. It is according to the indication. So here we have Ahmed. You said he's high risk. So I need to use a drug that modify the risk. So metformin is not necessarily the first line therapy here. The first line therapy would be a drug that would reduce his cardiovascular risk. Metformin is a good drug, would help, especially in obese people. UKPDS would fit with him, but we have more stronger data above the benefit we saw in the UKPDS for obese subgroup people on metformin. So the evidence of the GLP-1 or SGL2 would be higher. Then you need to think of the holistic approach for the person. So you want to start SGL2 or GLP-1. Correct? And you voted you want to get his HbA1c less than 6.5. Both can do that. So from cardiovascular protection, both drugs can do it. From getting Ahmed to below HbA1c 6.5 for Ahmed, who's already 6.5, both can do it. What other problem Ahmed has? Obesity. Which drug is stronger on obesity? SGL2 or GLP-1? So the answer is clear. Correct? So the right answer for Ahmed is Of course, before thinking of the drug, we have to think of the multifactorial. And the first one, before prescribing for Ahmed, is his lifestyle, his smoking, his eating, his KFC, his physical activity. All of this is very important because it would reflect on all of this. We need to think of antiplatelets. We need to know the target LDL for him. We need, of course, to use the right drugs for blood pressure. And so a multifactorial approach. And for glycemic control with specific agent in his case. So I think we've answered already that question. A GLP-1 or SGL2, both with TIC2 issues, the risk, the cardiovascular outcome risk is equal. In his case, the glycemic target would be achieved by both, but the weight issue for Ahmed would be better. So Ahmed left clinic with the lifestyle advice, with a once weekly GLP-1 with evidence, with an ACE or an angiotensin II of your choice, and with a high dose statin to get his LDL below 70. And we discussed aspirin, whether in his case he would take it or not, whether the epigastric pain is something we need to investigate a bit more before committing him to an aspirin or not. You need to weigh the pros and cons for this. Okay? Turbaha. If he was. Just use the mic so everyone can hear you.
If he already on GLP-1 for...
If he was.
Yes,
Okay.
for obesity medication.
Okay.
And then develop diabetes.
Yeah.
What will be your next choice?
Okay. So the question here is a very important question. And let me generalize the question first. If he is on a GLP-1 to start with because he's obese, I would ask myself the question, is he on one of the GLP-1s that has a cardiovascular data? If the answer is yes, I would say, great, let me add on. And the recommendation is very clear. If above target, use one of the agents. I'm already on GLP-1, add a SGL2. I'm on SGL2, add a GLP-1. And in both cases, it needs to be one with evidence. Okay? Clear? Use the mic.
If someone using GLP-1 for reducing weight, is there any chance, like after 1-2 years, he will be diagnosed with diabetes? Already he is taking GLP-1.
Okay, so what are the chances? You've started someone on obesity with a GLP-1. What are the chances that they will progress to become a person with diabetes? Well, we know that the drugs help, but it's not a bulletproof. Not everybody who's obese, who takes a GLP-1, will reverse the process completely. You might hold. It all depends on the individual. How much is his problem and how much is his lifestyle and the efficacy of the drug that they're using. But we'll come to the obesity case a bit later. Okay? So hold on keep your questions focused on the case because we have 4 cases for you, and inshallah many of your questions will be covered in the future cases as well. Okay. Refer. You don't. The essence of the guidelines is, number 1, act now on the things that you can act.
But sir, we don't have the luxury to prescribe
I'll explain to you.
injectable GLP-1
Sure.
agonists in our
So
clinic.
let me assume I work in a place where I don't have a specific drug for my patients. So number 1, I will address all the others, and then I will refer the patient to a specialist who has the ability to prescribe this. Now, let's assume the person cannot afford a GLP-1. Go for the second best for the particular case. Okay? Done? Okay, Dr. Hani.